All right. Well, good evening, everyone. If you're joining us from Eastern Canada, or good afternoon if you're out in BC. Um, my name is Eddy Lang. I'm an emergency physician in Calgary, Alberta. I'm the department head and prof there. I am also a proud member of Thrombosis Canada. I sit on the board, and it is my distinct pleasure to welcome all of you to this webinar, Essential Pearls for Frontline Management of Thrombotic Emergencies, very much targeting emergency department decision-making. And I know many of you are joining individually, and some of you are gathered in groups to watch this webinar. Welcome to all of you, and it's also not lost on me and us that this is a particularly difficult time for us in emergency medicine with staffing crises and post-pandemic fatigue and burnout that has affected so many of us and resulted in closures. So just to let you know, we're thinking about all that, and our thoughts are with all of you who are going through a difficult time. But let's get going on tonight's webinar. Next slide, please. We've got the chat feature up to make this as interactive as possible. So please, I'll be your moderator tonight, and you'll be welcome to put your questions and thoughts and comments into the chat feature. We'll also have some really cool polls up that you'll have about 10 to 15 seconds to respond to, just to get our finger on the pulse of the group for things that are your thoughts on various things. So I've got a few administrative points to cover. Next slide. So this program comes together through a scientific planning committee that I am pleased to share with the people that you see here. Dr. Ted Wein will be our main presenter tonight, but in about 7 days from now exactly, we'll have Sudeep Shivakumar and Jason Andrade presenting on some other cases. And this is the committee that put it all together. Next slide. My disclosures is I have received speaker honoraria from companies. And I do want to point out, though, that I do not accept any of these honoraria individually. My policy is to direct everything to either the CAPE Advancement Fund or our Calgary Health Trust supporting our EM trainee research. Next slide. So this program has received program support from Servier, and we are eligible for honorarium from both Dr. Wein and I are eligible for honorarium from Thrombosis Canada, but as I mentioned, I'm forwarding mine to the Calgary Health Foundation, and Servier may benefit from the sale of a product that will be discussed in this program in the interest of full transparency. Next slide. But we're going to try to mitigate this because all of our content has been peer-reviewed by Thrombosis Canada, and everything that we're going to be recommending is founded on good scientific principles and evidence-based recommendations, just as we stand by everything that's in our Thrombosis Canada guides and app that hopefully you are all using at the bedside to help support decision-making. Next slide. This is a fully accredited program, both through the Royal College and through the CFPC, so feel free to claim those. You can do 2 hours with the Royal College and 1 hour as a group learning program, because we're going to try to make this very, very interactive. Next slide. So big picture, we're going to just look at some best practice models and treatment recommendations for risk stratification in the area of cerebrovascular disease and risk for stroke. We're going to look at specific diagnostic criteria to plan interventions and management plans. And we're going to look at very special populations as well, as you'll see in a minute when you meet our 2 patients, and discuss the potential harms and mitigate risks, both thrombotic and bleeding risk of disease and treatment, trying to take as much of a balanced approach as possible. Next slide. So at this point, it is my distinct pleasure to introduce a good friend and former colleague when I worked in Montreal, Dr. Ted Wein, very well known in Canadian stroke neurology circles, very prolific author on guidelines, part of the Canadian Stroke best practice, an excellent presenter, I must say, and we are really, really lucky to have him with us. And he's going to present on these two cases. If it's looking like a geriatric emergency medicine evening, well, that may not be untrue, because trickiest population in which these issues arise. So without further ado, over to you, Ted.
Thank you so much, Eddie, for your kind words, and it's a pleasure to be here tonight. My personal goals tonight are really just to provide education and hope we advance patient care. And while these gentlemen do look elderly, the one on my left or your right while you're looking at the screen has much more hair than I do. They're both active and interactive and have great lives. And just because you're older does not mean that you stop living, and people should have the best quality of life possible. Eddie, do you just want to comment on this slide? I will comment quickly that on September 27th, there will be 2 more cases that will be presented. These are going to be different than tonight's program. There will be Dr. Shiva Kumar, who will be talking about a young woman with a DVT, as well as Dr. Jason Andrade from UBC, talking about a man with palpitations and chest discomfort. Perfect. So let's focus on my case, and I've helped design these cases really to highlight some new features that are in our Canadian stroke best practice recommendations and new guidelines that are out there, and to put some data out there to put things into perspective on how I feel, or at least the guidelines feel, patients should be managed. I've received grants from the following companies and consulting fees for clinical trial design from both AbbVie and Ipsen, not related at all to tonight's presentation. The other disclosure is I am the former chair of the stroke prevention guidelines, as well as sit on the steering committee of the Heart and Stroke Best Practices Stroke Care Committee for all guidelines now, and I will be promoting these in the concept of best patient care. So what I'm hoping to do tonight is that you all have a much better idea of how to evaluate patients with TIA and minor stroke, and look at what the guidelines have that have changed from prior ones. Have a better understanding on the importance and timing of investigations, as well as which ones give you the greatest yield in order to prevent subsequent events, and look at investigations as well as appropriate therapies for secondary prevention. So let's start with this first gentleman here, Mr. HN. He's an 80-year-old gentleman, and he presented with a TIA some 48 hours ago. So he says basically 2 days ago, I had an episode of right facial droop, right hand clumsiness, and some trouble with my speech. It lasted for around 45 seconds. So fairly good convincing history for a cerebral vascular event here. He has a past medical history of hypertension and type 2 diabetes mellitus, so clearly vascular risk factors is there, as well as a 40-pack-year history of smoking. So a number of risk factors here, a concerning event, and he pops into your emergency room 48 hours later. So he's not ultra early here the first couple of hours. He's not even within 24 hours. He's really at the tail end of 48 hours. So the first polling question I have for everybody is, how fast should this gentleman be evaluated? He presents within 48 hours, so should we do it as soon as possible? Do we have a 24-hour window, a 48-hour window? Or since it's 48 hours ago, should we go ahead and just do it within the week? And as I look at our results coming in here, majority of people, 80% here, are saying it should be done as soon as possible, 9% within 24 hours. So excellent. So the answer is correct. Oops. The answer is it should be done as soon as possible. And reality is you have an upfront risk of having an event, and that biggest upfront risk is within the first 48 hours. If we look at the timing and evaluation of what should be done, if we look at our stroke prevention guidelines, and these can all be found at strokebestpractices.ca, we stress that urgent brain imaging, be it CT or MRI, in reality is CT for most of our centers, as well as concomitant neurovascular imaging and CT angiography is recommended, should be done as soon as possible when patients arrive. And the official cutoff time is patients presenting after 48 hours from onset should have their evaluation done still as soon as possible, because they're still at high risk. And I would say less than 48 hours is ultra urgent, ASAP, get them up there, get them imaged, and I'll show you why in a second. And after 48 hours, we've changed it to as soon as possible. For those of you who recall the old guidelines that I had written, we had written that it should be done as soon as possible from 24 to 48 hours, and then a little bit slower afterwards, but we're really trying to simplify it and really stating that within 48 hours, you need to get as much information as you can, stat, and after that, it should be done as soon as possible and probably well within a 24-hour period. So the question then becomes, what tests should be done? And I'll be showing some information to justify what we're doing, but what tests should we be doing here? Do we just do the CT, the CTA? Should we just check a lipid level on these individuals? Do we get our Holters, our echoes, our ECGs? Should we do all of this stuff, some of the stuff, none of this stuff? So great. So I'd say the majority of people are saying that we should do all of the above, which is correct, although they have different degrees of importance that we would entertain. The CTA is important, but you need to do the CT to make sure there's no mass up there. LDLs are important, and for those of you that LDL then after 48 hours will be artificially low, so it needs to be repeated again in 3 months, but clearly implementing early statin use is very helpful. Getting those Holters as soon as possible, looking for paroxysmal atrial fibrillation is essential. The echocardiogram I'm going to talk about in a second, a little bit less important and de-stressed in our guidelines, but clearly something very reasonable to do. And of course, everyone needs to have a baseline ECG to ascertain what should be done. So my answer would have been all of the above. And most importantly, we really need some form of 24-hour cardiac monitoring, be that telemetry overnight in the ED, be that people have iWatches now. I'm very happy with that as my cardiac monitoring. There's some evidence that 3 serial EKGs may be just as good as a 24-hour cardiac monitor. But a list of investigations where really the ED's responsibility to get them initiated, predominantly if you don't have support from neurology here. So what about echocardiograms? Well, we do them all the time. The actual yield of an echocardiogram is less than 2%. And in fact, we have recommended that echocardiograms should be reserved when your Holter and all your other risks, other tests, CT, CTA, are all negative, and you really don't have a clear-cut choice, that the echo can be implemented sort of afterwards, because reality is the yield is low, time-consuming procedure, the cardiologists are overwhelmed, and so I'm not routinely using that as a first-line therapy, but clearly something that once you get the results of your other tests, if you don't have an answer for the cause of your event, then that echocardiogram is really important to do. For people who are new for 2020, so these new stroke prevention guidelines are dated 2020, but due to the pandemic, were only published in December of 2021. So they're still relatively new despite the date that's there. We also are looking more and more for patent foramen ovale in young people. And for those of you under 60, I will call you young for the purpose of this lecture. So people with strokes less than age 60 and you don't find a clear-cut course, PFO closure, if found, may be an appropriate intervention for people. And so we're recommending that the cardiologists do contrast enhanced or agitated saline transesophageal transthoracic echo, and then you can follow that up with a transesophageal echo afterwards, should that be warranted. So for this gentleman, let's assume he had a TIA, CT-CTA is negative. What are we going to do for therapy? That's the question I get all the time, is what do we put him on? What do we put him on? So this gentleman had his transient event of facial droop, some loss of language, some right hand clumsiness. What do you guys want to do? Do you want to put him on a DOAC? Do you want to do dual antiplatelets for 21 days? Do you want to do dual antiplatelets for 3 months? Should we just put him on an aspirin or clopidogrel in monotherapy? Or should we put him on low molecular weight heparin? And let's see what people say here. So this is a really interesting one, and I'm going to see what people say, because there's actually several correct answers here. There's actually a correct answer and then an acceptable answer as far as I'm concerned. So majority, 9% said a DOAC, 56% said dual antiplatelets, 6% said dual antiplatelets for 3 months, 25% said an antiplatelet in monotherapy, and 3% said low molecular weight heparin. So reality is that DOACs are not really indicated unless we have a clear-cut atrial fibrillation, and other than that, we don't have a clear-cut indication. So I'd scratch that one off the list. Number 2 that I'm going to scratch off the list is dual antiplatelet therapy for 3 months. And in fact, dual antiplatelet therapy is recommended for 21 days, and that the risk of GI bleeding goes up significantly after 21 days. So we really try to cap it at 21 days. Why do you see people with 3 months of dual antiplatelets in neurology sometimes? Well, there is some evidence that people who have intracranial atherosclerotic disease that you would see on your CTA may benefit from a longer duration of dual antiplatelets, but that's an exception and a rarity and not applicable to this case. Low molecular weight heparin is not indicated either, ever in these scenarios. So the two choices that I leave for you are dual antiplatelets times 21 days or antiplatelet monotherapy. So why am I hedging with my guesses here on what should be done? Why is there not a clear-cut answer? So I'm going to tell you the following. Antiplatelet monotherapy is indicated for anyone with an event. And while dual antiplatelets are really beneficial in the short term, reality is the only two trials we have, the POINT trial, well, three trials, the POINT trial, the THALES trial, as well as the CHANCE trial, all looked at individuals presenting with symptoms within 24 hours. And this gentleman that we just had actually is presenting at 48 hours. So he's outside of the traditional time window that was looked at in any of these studies. Saying that, I think community practice now is really involved to putting everybody on dual antiplatelets for 21 days. But reality is, if we look at these studies, they only had people within 24 hours of symptoms. And one of the studies did it within 12 hours of symptoms. And the reason they do that is because the upfront risk of having an event is so early on. So I would say the correct answer is technically antiplatelet monotherapy as stated in our guidelines. However, the dual antiplatelet therapy has really become a community standard for all people, irrespective of the onset. And I think both of these would be very reasonable approaches to your patient. Here. So if we look here, we recommend that people be loaded with at least 160 milligrams of aspirin. And in people who have dysphagia, don't forget there's rectal aspirin that can be given, although it comes in a dose of 325 milligrams. But I'll point you to this last third point here. Antiplatelet therapy should be started as soon as possible after brain imaging has excluded hemorrhage within 24 hours of symptom onset, and ideally with 12 hours. And that's because that's what the two trials really showed us, is that 12-hour to 24-hour period. And that's why the monotherapy is probably the right answer, but I think the dual antiplatelet therapy is very much acceptable. I think what's most important that everybody should get their antiplatelets before they leave the ED. If they have a minor event and they're going home, please make sure you start therapy. It's not something to start the next day. It really should be started ASAP. So dual antiplatelets here, we have a whole section on this at strokebestpractices.ca. But basically, we recommend it for the first 21 days. And in individuals with intracranial stenosis, I have here, can be for somewhat longer period. And reality is we looked at individuals with minor stroke in these trials. So these were people who had little TIAs or people that had non-cardioembolic strokes with their NIH stroke scales of being less than 3. So the next question that's not answered in our guidelines is what happens with a person with a big stroke or if their NIH stroke scale is greater than 4 and they're being admitted? Do they benefit from antiplatelets? The answer is, I don't know. We don't have any data for that. And looking at my colleagues, some people will put them on dual antiplatelets and some people won't. If it's a completed event, I'm not sure there's much to do to prevent something else, but they're still at high risk for recurrent events. And again, investigation should be done in a timely fashion as soon as possible. If we look at the different dosing that's out there, and you may see your neurologist or internist prescribing different things, we have two different dosages out there. The CHANCE trial, which was done in China, used a loading dose of clopidogrel of 300 milligrams. The POINT trial done in the United States used a loading dose of 600 milligrams. And these trials also use different loading dose of aspirin, anywhere from 160 to 325 milligrams. In our guidelines, either one is good. Whatever you think is best for your patient, go ahead to do that. I'd also point out that there's another trial called the THALES trial that used ticagrelor. So that would be 180 milligram loading dose followed by 90 milligrams BID for 30 days. Saying this, the ticagrelor study had a higher bleeding rate, and it's something that I personally have shied away, but is also another great option we have for our patients, predominantly should they have an allergy to clopidogrel, for example. So very, very important stuff, and different dosing that you may see out there with no clear-cut dose of what range of loading of these drugs should be given to individuals. As I mentioned before, people with intracranial atherosclerotic disease can be put, and this is new for 2020 here, this was called the SAMPRIS protocol, which was the trial looking at intracranial atherosclerotic disease, and we recommended it for 3 months is what they did in the study. So we do have new therapies out there. dual antiplatelet therapies really should be started within the first 24 hours. You have a range and dosage of clopidogrel that you can offer your patients, as well as the use of ticagrelor as an alternative, although at slightly higher GI bleeding risk and for a slightly longer period of time. So why are we saying you should do this short-term dual antiplatelet, or why should we get our investigations done as soon as possible? I'm going to show you two studies, one done by my colleague David Gladstone and former chair of the stroke prevention guidelines, is that he clearly showed that half of the events after a TIA or minor stroke happen within those first 48 hours, as you can see here with the event rates here. That doesn't mean after 48 hours that there's no risk at all. In fact, over the next 20 to 30 days, you can still see there is more risk, but it's not as significant, or the number of events are really upfront at that time period. This was one Canadian study, and it's from 2004, and the big question is, hey, do we still have these problems? You know, have we done better in triaging our stroke patients that we're doing our testing anyways and we're not seeing event rates? Well, unfortunately not. 5 years later, on the study from the US, we continue to see the high event rate that occurs soon after TIA. And if you look at the percentages here, I just want to see people on the same day of their TIA, almost 18% of these individuals are going to have a subsequent event. And if we do the next day and 48 hours, you're going to see that you're almost at 42% of people that have an event within 48 hours. If you want to know when that rate starts to fall significantly, I'd really say after day 5, the majority of events have occurred and we get these little outliers here. But it's really those first 5 days. And when I look at our patients who presented at 48 hours, so he's at the tail end of this day here, well, half of the events occur in those first 48 hours. We still have a good, over the next 3 days, 10, 25, 30 or 40% of individuals that are going to have more events. And that's why those tests should be done ASAP. Identifying a carotid stenosis and going for endarterectomy and starting dual antiplatelets is great. Identifying paroxysmal atrial fibrillation and beginning your NOAC is great. There's so much we can do to try to prevent the recurrence of these events if we actually get all the information we need. And I hope this pushes you guys to sort of push forward and get the system to move a little bit quicker to help patients, because events do happen ultra early. People will get worse in your department. People will get worse in your department if they're on telemetry for 24 hours, and it's going to be around 40% of those patients. So there's a lot we can do, and that's why we really need to push investigations and start those antiplatelets or those dual antiplatelets as soon as possible, because people really aren't out of the woods once they leave your ED after those 24, even 48 hours. And to me, the biggest risk factor is that initial week, which is something we had in our old guidelines. But from a systems driver here, we really want to point out that we shouldn't be nonchalant about saying, oh, there's a TIA in bed 4 here. You know, let's just do the workup. It really should be expedited because things will evolve in front of you. So what happens? Well, he presents 5 days later now with a bigger stroke. And this time he has a sensory neglect. His CT scan shows that he has a wedge-shaped infarct. On further history to give you, he drinks 3 to 5 glasses of alcohol per day. He has a low body mass index. You can see he's a little bit thin. He has a mild anemia, has a low albumin. And that's sort of where we're evolving with him. And it's like, where are we going with this gentleman? So, you know, stroke recurrence rates occur with different types of strokes. And we have cardioembolic strokes. We have large artery strokes, such as carotid stenosis. Then we have our lacunar strokes or small vessel disease strokes. Point out that around 20% of strokes are undetermined. And then we have the famous category of other, where nobody's really sure what's going on. But look at the upfront risk for this line over here for large artery or carotid stenosis strokes. See how those events happen in those first couple of days. And then let's look at cardioembolic stroke. You have a line almost going straight down in those first 2-3 days. So implementing therapy here is really important. This gentleman's at day 48 and has had another event within 5 days. So statistically speaking, this guy either has a large artery event or highly suspicious for a cardioembolic event. And maybe we didn't have our Holter or it was only for 24 hours and we need to do longer cardiac monitoring to identify what's going on. So what do we do next as the next thing for this gentleman? Should we do 30-day cardiac monitoring? Should we do a transesophageal echocardiogram to look at his aortic arch? Do we do a transthoracic echocardiogram if it hasn't been done? Do we repeat the CT angio to see what's going on in this individual? Do we do multiple things for this man? Yeah. So most people say, let's do a CTA, let's do the cardiac monitoring on him. And 45% want to do the TTE if it was or was not done. So those are all great answers. I think 30-day cardiac monitoring is the most logical thing. The CT and CTA hopefully were done the other day, although he's had another event, and if he's within the time window for an intervention, then the CTA should be done. We want to make sure there's been no bleed or anything else like that. A repeat ECG should always be done, but I think reality is he should have had the TTE in his last admission. The TTE, a little bit rare to have aortic arch atheroma, would be another reasonable thing, but for me, I want to point out that in idiopathic stroke, if you do prolonged cardiac monitoring, 1 in 4 patients will be able to document that they have paroxysmal atrial fibrillation, leading to a change in therapy. TE is looking for aortic arch atheroma. May be helpful, but the treatment is still to put them on the statin that they should have been on in the first place. So don't forget that prolonged cardiac monitoring is currently indicated, and we have a whole section in the guidelines to help support the use of prolonged ECG monitoring. And reality is people who have cortically based strokes are individuals that we're really concerned about. This gentleman presented with a neglect, cortical involvement, wedge-shaped infarct, as I described it before. Think really of cardioembolic events when you do that, because those are little clues for these individuals. Everybody should get at least 24 hours of cardiac monitoring, as pointed out in point 2. But for patients who are now being involved, like this gentleman, for suspected embolic strokes, prolonged cardiac monitoring is recommended for at least 2 weeks. And the biggest problem is the limitations in these devices that are available at many institutions. You should be most concerned for paroxysmal atrial fibrillation in patients aged more than 55. And I've gone now, as more and more people have their iWatches, there's actually a great cardiac monitoring app on that should be used. But we really need to push to getting this technology out to people, either through the hospital or through home devices, but more and more devices are coming out on the market. So he sent back to rehab again, and now he comes back again. And this time the guy has a DVT in his leg. If we get the results of his 30-day loop monitor, let's say I'm wrong with the times here, but let's say the 30-day loop monitor is normal. We did the transesophageal echocardiogram, low yield in this age group. Don't really see anything else. What do we do with this gentleman's DVT? And is there anything we may have missed that we should have thought of before? And that's what I want you guys to think about. What do you think we missed in this gentleman? He's had 3 strokes in a 15-day period. And what did we do wrong? And what are our next steps, if any? So I want to say that there were several red flags that we did not really address. This man is older. He had a low body mass index. He had a history of smoking. He had a history of ischemic stroke. He had no known cancer, but he did have a low albumin, I told you, and he did have a low hemoglobin as well. And those are all pretty marked risk factors for what we're now looking at as cancer-associated stroke, or some of the risk factors that may predict who may actually have an occult malignancy that's leading to a hypercoagulable state. And I'm not throwing this as a red herring, but I do want to point out that 1 in 4 strokes coming through the ER leave with no standard investigation. And so we've put together a new chapter in our stroke prevention guidelines on risk factors for cancer-associated stroke, and trying to put out some little red flags for you guys to understand what some of those markers are. And I'm just going to review them. Older age, men, history of alcohol use, smoking, and so heavy drinking is defined as 3 glasses or more. And then from a serological perspective, a low albumin, a low hemoglobin. While we don't really test D-dimer, fibrinogen level, CRP, and LDH levels, those are other things you may want to think about. But frequently we do have that low hemoglobin, and frequently we'll get the albumin on people, particularly in our elderly patients. So that's what I really want you guys to remember. This is a new etiology of stroke. It's a whole new section we've put into the guidelines. It's something that we don't think of very often, that really may be something that can diagnose something that may have been missed. So there are some guidelines, and they're a little bit different from some of the other DVT guidelines, and they're not really strongly evidence-based because there's only small studies on this. But low molecular weight heparin may be considered to start with and then transition to a NOAC or a DOAC. We have no high-level randomized controlled trials for this. But there is a little bit of some pilot trials out there. There's the TEACH trial that looked at low molecular weight versus aspirin, and a post hoc analysis of the Navigate ESIS trial showed no recurrence rates in terms of rivaroxaban and aspirin. So not a great treatment change that's going to come here. We clearly have to treat the DVT as expected, but in terms of subsequent stroke prevention, there's not one therapy that really rises to the top as being better for stroke prevention, not for the DVT prevention. So for our 2020 guideline, I'm just going to direct you to this entire section we have in section 11.1 of strokebestpractices.ca, which will take you through a lot of the workup and investigations for cancer-related stroke. And again, we saw nothing on the echo to suggest morantic endocarditis and no other hypercoagulable things. But more and more as we look further with these little signals that you can see in serologies and unexplained strokes, more and more we're finding malignancies that had gone undetected for our patients. So lots of decisions to make. Thrombosis Canada has a great section on DVT and PA and cancer-associated patients. And I hope this will just give you a different view or different scope on something in the field of cancer that we don't routinely talk about in our traditional stroke talks. So key leading points for me is up to half of recurrent strokes occur within the first 24 to 48 hours. You still can have a significant number of events by days 5 to 7. And if these people walk into your ED, remember, they can evolve in front of you. In fact, 70% of them will evolve in front of you if you actually look, and the test should be done as soon as possible. Patients presenting with a TIA should get all investigations done ASAP, and please start the antiplatelets as soon as possible. Technically, dual antiplatelets within the first 24 hours, but I think it's very reasonable to try it at a later time point, for several days later, but not evidence-based at this point. So, Eddie, do you want me to stop there?
Yeah, I think that'd be a great idea, Ted, just to make it more interactive. So thank you so much for that case. You've elegantly pointed out how the first few days is high risk for TIA patients. But what do we know about how effective early treatment is? So Dr. Vig has asked if we know what the risk reduction and the number needed to treat might be for early initiation antiplatelet therapy in this setting.
Yeah, so that's an excellent question. So there's actually been 2 large trials, and I didn't include them here because I live in Quebec. And one of them was called the SOS TIA trial, and the other one was called the Express trial. And guess what? One of them was an English study, and one of them was a French study. And what they did is that anybody who came in with a TIA or minor stroke, they did the imaging immediately. So CT, CTA, got people their cardiac monitoring within 24 hours, checked their lipids, and immediately initiated antiplatelets, statin agents, as well as antihypertensive agents. And they were able to show an 80% reduction in subsequent events in patients. These were 2 large prospective trials that were done in the UK and France. And so the answer is, does this translate to a benefit? The answer is absolutely. And for those of you that maybe use the ABCD2 scale to assess risk, which we took out of the guidelines in Canada, because it seemed that most Canadians were not doing it, and we were doing a really good job of doing that. The ABCD score was actually used in those initial trials to try to triage who's at higher risk, at lower risk, but they really were quite effective at proving a point that we've longed for so long. And the studies are from 2005, 2006. So the answer is 80% reduction in subsequent event rates by starting everything immediately. So good, 2 solid studies out there. There was one study that came from your hometown, Eddie, with Andrew Demchuk, the FASTER trial. And they were trending to show good support by doing everything, but unfortunately they were unable to enroll enough patients quick enough before they lost their funding. So outside of those 2 large trials, and significantly large trials of, I think there were 3,000 patients, I don't have any other data show you, but it clearly showed that early treatment had such a huge impact on protecting our patients.
Thanks, Ted. And I just wanted to follow up with some of your suggestions on early and aggressive investigations. I mean, I work at the Foothills Hospital, which is what you just mentioned, arguably one of the best known stroke hospitals in Canada. And we are blessed with a stroke prevention clinic that we can send this kind of patient to the next day. Because getting them admitted and trying to embark on all of these investigations while they're in the emergency department is just not going to be a feasible item for the vast majority of Canadian emergency departments, especially given the pressures that we're under now with so many admitted patients in the emergency department and beds upstairs at such a premium. So would you say that the bare minimum for a workup, if you do have reasonable follow-up, would be to get the CTA and that the 30-day loop recorder, although ideally started as soon as possible, doesn't, I mean, you wouldn't be violating the guidelines if you didn't initiate all of the extensive workup for cancer-related stroke and arrhythmias in the emerge on the day of presentation.
So absolutely. If you're going to ask me where your biggest bang for your buck is, and the first thing we have in guideline is urgent neuroimaging and neurovascular imaging. You want to make sure, A, that this is a stroke and not a tumor and the person doesn't have an AVM or a little bleed, number one. And then what can you do best to help a patient? If we can identify that carotid stenosis, that's the biggest bang for your buck. I mean, we're talking about 70 to 80% relative risk reduction, doing an endarterectomy on that gentleman or woman within 24 to 48 hours. That is your biggest bang for your buck. Number needed to treat, 2. You can't do much better than that. So that's one key thing to do. I think while they're in the hospital waiting for investigation, having them on telemetry. So as they're waiting to go for their CT, having them on a monitor is really important. I think another cheap man's telemetry is to do 3 sequential EKGs or serial EKGs on people. It's been shown to have the same yield. But the more cardiac monitoring you get in there, the better. The lipid profile is easy to get. The LDL is easy to get, although many emergencies don't do that. More and more, we're starting to migrate to non-fasting LDLs for patients, and soon we'll be going to apolipoprotein levels. But those are the bare minimums. If you're going to ask me what the yield, and I think I said this and we showed in the guidelines, the yield of that echocardiogram, 2% of finding something that may influence you. And if you're going to ask me how many, I see around 5,000 stroke patients a year between my 2 centers. And if you're going to ask me how many cardiac thrombi do I see a year, 1. So not so common there. But if you can get those first things done, that endarterectomy and that anticoagulant done, I think you're going to do really well. And you're going to do really well because of this one here. Look at this. Large artery events, that line goes almost straight down in those first couple of days. Cardioembolic events, really in those first 48 hours. Once we get to lacunar strokes and these smaller things here, much lower yield for our return. So my 2 favorites are what I just said: telemetry, serial EKGs, and getting that CTA done. And then getting on those dual antiplatelets is, to me, will protect a huge percentage of your patients.
Awesome. Ted, in the interest of time, let's go to your next case. There's a question about paroxysmal AFib, but I think you might be covering it. So go right ahead.
So let me go through this here, and I'm going to speed a little bit. So the next case, we're trying to focus on the elderly patient and optimal treatment for paroxysmal atrial fibrillation and what happens in the elderly. So this gentleman's 86 years old. He has paroxysmal atrial fibrillation. He has a TIA and transient aphasia with a right hemiparesis lasting for 15 minutes. Sounds very cardioembolic to me. Has history of severe osteoarthritis and spinal stenosis. He's had several falls. He's never hit his head, but he has multiple bruises. He's on apixaban 2.5 milligrams twice a day. Has diabetes, hypertension, congestive heart failure, coronary artery disease, osteoarthritis, and the spinal stenosis. His weight is 75 kilos. His creatinine is 94 milliliters per minute. So is this man on appropriate therapy with his DOAC? The answers are yes or no in the interest of time. So this is fun to watch. So we have a 50-50 split of everybody here. Perfect. All right, so the answer is, sorry, 50-50. Why can't I get my slide to work? So the answer is no, this gentleman is not on his appropriate DOAC. While he is on a DOAC and he is on a Bixaban 2.5 milligrams per day, the answer is that he's underdosed on his DOAC, and I'm going to get to that in a second. What investigations would be useful in this gentleman? Should we do a CT head to rule out a subdural given his multiple falls, a CBC and a PT given his multiple falls and the bruising that he's describing? Should we investigate the cause of the fall? And do we need to do a Berg? Should we get physiotherapy to come in on the weekend and see, like, you know, is this guy at so many risks that we can't put him on anything? So 80+ people saying do the CT head to rule out the subdural, 50% to do the CBC, 63% say to investigate the cause of the fall. So that is true. I think all of these things are useful things that will be very helpful and should be done. We need to rule out a subdural. This guy's fallen multiple times. We need to do a CBC, make sure there's no other coagulation problem going on that we need to investigate. Always look for the cause of the fall. I don't know how many patients I've seen who've had a fractured hip go to the OR, and then they get consulted 3 days later because they're hemiparetic on that side, and they actually had a stroke that was the cause of the fall. And then finally, the Berg. Do not anticoagulate because of their fall risk. You need to fall over 300 times on warfarin and probably higher with the DOAC. That should be an exclusion, but I do think you should do the Berg to evaluate a patient's safety for other things at home. So would you consider him failed? We're not going to do this because we just did this. I'm going to just say he's inappropriately underdosed, and we'll get into why he was, or what those criteria are on a second. And people were split 50-50 with that. So family mentions that older people are at higher risk of bleeding. And the question is, if he really needs to take a DOAC, should he take it? I mean, is it worse to bleed or is it worse to have a stroke? And the gentleman, like all my patients, I don't like my bruises. Let me just stop it. Let me take half dose. Will that just be as good? And the answer is no, but this gentleman was underdosed. There are several criteria, and we're going to get into them shortly. But the number one cause of stroke on a DOAC patient in the elderly is inappropriate underdosing. And the other things you need to think about, should you have a stroke on a DOAC, is, are they compliant with the medications? Are there drug-drug interactions? If you're on rivaroxaban, are you taking it with a meal to help aid GI absorption? Patient compliant with everything, and have the physicians prescribe the right dosing for our patients. And when we look at that, the majority of the time, probably around 70 to 80% of the time, is one of those issues that explains why a patient has had an event on their DOAC. Always look for other causes. So I'm always saying, should we switch to something else? The answer is, let's look for alternative stroke etiologies. Do they have AFib, but maybe they have a carotid stenosis? Maybe they have uncontrolled hypertension and they had just a lacunar stroke. Maybe they had a dissection, something else to think about. And so are there other diabetes, hypertension, dyslipidemia undertreated? And once you take all those things into consideration, say 90% of the time, you won't find anything else as a potential etiology. Treatment in the elderly is a big issue because they're the highest and most vulnerable patients to get events, but they're also the most vulnerable to have side effects from their events. And so we really want to look at adherence, correct dosing, and avoid drug-drug interactions, and also make sure that the diagnosis of an event was actually there. I have so many patients with non-specific numbness tingling that are labeled as TIA, when the majority of the time they are not. So the guidelines now and the CCS has this whole section on frailty and the elderly and who should be followed. I want to point out that despite the bruising, and as hideous as many people don't like that, if it's not killing you, stay on it. As you get older, age is the biggest risk factor for stroke. And as you get over 85, it gets worse and worse, your event rates. So why do we want to stay on this? And what is the bleeding risk? I'll tell you two things. If you're old, you're at higher risk for ischemic stroke. If you're old, you're higher risk for hemorrhagic transformation. But if we look at the preferred trial in atrial fibrillation here, if you look at the over 85s, red, thrombotic events, blue, bleeding events, maybe we should have switched the colors, is more appropriate. But I just want to point out the thrombotic events always outweigh the bleeding events. And that's what I always stress to my patients, is that you're at higher risk of bleeding, but you're at much higher risk of having an ischemic stroke. So we also see that here in the Japan Rhythm atrial fibrillation trial. Again, event rates higher for the ischemic stroke and lower for major bleeding. But again, bleeds can be corrected, although you do die, and I recognize that. But invalidity and quality of life really has to be taken into consideration. And then I'm going to skip this for MI, but we have the same thing here for event rates. So what's going on around the world? In 2016, I had a paper showing marked underdosing. We looked at stroke cause in our DOAC patients. 80% were caused by physician inappropriate underdosing. From this article from Seiss and colleagues from Greece, if we look at apixaban, almost 40% inappropriately underdosed. We look at the dabigatran, around 7% underdosed, but 25% of the individuals with rivaroxaban were underdosed as well. So it's a worldwide phenomenon. Physicians trying to be a little bit more cautious and trying to acquiesce to maybe patient demands, maybe acquiesce to physicians' concern regarding bleeding. So why was this man underdosed? Well, he was age 80, which is good, but there's two other criteria you require to take the lower dose of apixaban. A weight less than 60, and trust me, the man's way over 60, and his creatinine was 95. So he only had one of criteria, and he should have been on the 5 milligram dose. If we look at who's an age-dependent dosing in the DOACs, it's dabigatran and apixaban. The rest are really influenced by creatinine clearance. I want to point out rivaroxaban approved for creatinine clearance 15 to 49, as well as edoxaban also has that indication now from several months ago. If you have any of these criteria for edoxaban, lower creatinines, weight less than 60, or on a PGP inhibitor, only one criteria for edoxaban warrants the 30 milligram dose. Please make sure you're following the monograph, because the majority of strokes I see as a neurologist are in individuals who have not followed the protocols here. And that's really still accounts, as you saw in the other trials, from 40 to 60% of our patients. So as I mentioned, the CCS now has clear-cut guidelines on what to do in frail, looking at older age, female sex, history of falls, or reasons why people inappropriately put people on lower dose, but we are making our patients vulnerable to subsequent risk. And please don't forget that. I want to point out that we have our stroke risk, because all the DOACs are excellent, but if you look at individuals over 75, it's really apixaban and edoxaban that shine as having lower bleeding rates in this older population. And again, these are indirect comparisons. We have no head-to-head trials for these individuals. If you want to look at data for 80 to 85-year-olds, for me, that's more important. At McGill last year, our mean age for a stroke was 82 and a half. My mean age for a stroke at St. Mary's this year is going to be 90 years old. So we're seeing more and more octo and nanogenarians, but do we have data to support the safety of drugs? Well, if we look here, stroke and systemic embolization, it doesn't matter what your age group is, you do really well, and it always favors the DOAC, or trends to favor the DOAC of what's being helpful. I think the biggest change is really in bleeding risk that we see, and I'm pointing this out because there are guidelines from the American Geriatric Society. You can clearly see in the ENGAGE trial with edoxaban and in the Aristotle trial with apixaban that bleeding rates stayed much lower than in Rocket AF or Rely with the other two agents. So if we look at the benefits in individuals over 75, all these drugs are great. You can see that over 75 and less than 75, the DOACs always do so much better. We have decreased event rates in these individuals. Where we see a difference between age is really in the drugs of what shows decreased bleeding, as we see here with edoxaban and apixaban. And if you look over here at Rely and Rocket AF with rivaroxaban and dabigatran, these drugs sort of lose their safety profile as we get to older populations. So there's actually directions from our guidelines from the American Geriatric Society that said, if you're going to use dabigatran and rivaroxaban, that perhaps that due to increased bleeding and GI bleeding, it should be used with caution, and they sort of guide you to the other two agents as potential therapies. What else can I tell you? I want to point out bleeding is always there, but who gets the biggest bang? It's the people over 75 are at higher risk for stroke, age independent risk factor. You're going to prevent 144 strokes by treating individuals with your oral anticoagulants. This is data from the Aetna AF program, an ongoing phase 4 trial. I'm not looking at phase 4 trial for efficacy data. I really want to see what real world experience tells us in terms of safety. First safety measure on my right here, intracerebral hemorrhage rates, 0.3. That's amazing. Ischemic stroke rates, not, again, very, very low. As you get older, Over age 85, that event rate goes to 1.3, still extremely low, but you can see that major bleeding is also up on that edge as well. So a lot of good safety data out there. If we look at the frail elder patients, again, we have all these event rates, really less than 2% for the most part. And the more frail you are, yes, the more events you're going to have, but you're also at higher mortality and higher risk for stroke. And that's a balance that has to be chosen by you. So what are the options now for Mr. K? Do we increase the Bixaban to 5? Do we put him to dabigatran? Would you put him on warfarin? Would you put him on edoxaban 60? Or would you put him on edoxaban 30? And so most people are putting him on edoxaban 5 BID. A couple of people are putting him on edoxaban 60 milligrams. Absolutely. I'm going to stop this just in the interest of time. So almost the big majority say edoxaban 5. I think both of these are perfectly fine. I think they're both great drugs. Both have their own pros and cons, but those would be the two safest drugs based on the guidelines. So what happens now if his creatinine clearance goes to 25? Would you increase him to Bixaban 5 BID? Would you put him on dabigatran 150 BID? Put him on edoxaban 30? Or would you put him on rivaroxaban 20? Do we have a poll for here? So again, edoxaban 30 would really be the correct dose. The rivaroxaban can be used if you want to go down to a dose of 15 for the low creatinine clearance. And again, Bixaban doesn't go by creatinine clearance. It goes by a creatinine of greater than 133 that it should be excluded. So I would go with the answer of edoxaban 30 here, whoopsie, as the next appropriate thing to do for this gentleman. Please don't forget, as we put people on drugs, creatinines need to be measured. And in fact, in this gentleman who has a low creatinine clearance, the guidelines suggest that they should have their creatinines checked every 3 months. And if you have someone come in with a stroke, I would always check their creatinine clearance to make sure they're on the right dose of the drug and that they haven't taken a renal hit and should be on a lower dose, which happens all too frequently. So I think, and I'm sorry if I rushed, I just want to finish on time here, that the NAF reinforces the safety of edoxaban in the real world. I want to point out we really do have data on people greater than 75, 80, and 85. The American Geriatric Society has clear-cut guidelines that suggest against the use of rivaroxaban and dabigatran based on indirect comparisons, based on higher bleeding rates that we see that we did not see with edoxaban or Bixaban. And most importantly, please check those creatinine clearances on a periodic basis. Eddie?
Hey, thanks so much, Ted. That was an amazing talk. Great overview. Thank you for covering that so efficiently. Dr. Gepregs in the chat has raised the question of whether you would always initiate a DOAC and stop dual antiplatelet if you were to discover paroxysmal AF, either an episode in the emergency or on follow-up Holter or even longer-term monitoring. Is this just a no-brainer? You would always switch over to a DOAC at that point?
So for myself as a neurologist, as soon as we identify AF in any way, we will switch directly to the DOAC immediately. I know for the primary prevention, there's been the struggle of how much AF do you have. And I think once you're symptomatic from an event, I think it really warrants switching to the DOAC. Number two is we've had 2 trials called ESIS, which were embolic stroke of unknown source, where people were randomized, one to rivaroxaban and another one to dabigatran. And I think the most reassuring stuff from both of those trials is that the bleeding rates were really low when compared to the antiplatelets. So I'm not sure we would really err on the side of caution. And I would point out that there are a number of trials now looking at non-cardioembolic stroke, as well as what the benefit of these DOACs are. And, can we get bigger bang for our buck and broaden the indication for these drugs if we can show better efficacy, or at least equal efficacy and safety there in order to cover our bases. So that's really good. But as soon as I see that AF, I'm really low threshold to automatically switch to that DOAC ASAP.
Great. Thanks, Ted. And I guess, hard to know where we're going to land on this, but with the more widespread availability of home monitoring and cardiomobile and other tools to to detect arrhythmias at home. I wonder if that's also going to help us. I mean, I think we need some more data, but the having to consider it is probably going to become more and more common thing.
Yeah, I think we really need to adapt. I think we need to be open-minded. I have to tell you, I just saw a patient earlier today, 84-year-old gentleman, and had a TIA, and we're going through the whole workup. And the daughter comes in, she says, oh, by the way, on his watch, is this important? And it has like the AFib detection that they weren't really sure what to do with. So I think we're going to be seeing more of this. And I think this is wonderful. I think this is going to take off some of the burden of doing some testing that's a little more complicated to arrange through the healthcare system. And I think we're going to identify people with a treatable disease that we can really have a significant impact early on. So I'm really excited about this. And I've been trying to convince my mom to get an iWatch, which she absolutely refuses to do at age 86.
That's awesome. Ted, hey, we really appreciate your expertise here. I mean, I think you've demonstrated nicely. There's a lot of complexity and nuance in the frail elderly and in patients with end-stage renal with renal dysfunction. Just maybe a quick one about commenting on when you would anticoagulate patients with AFib and who are on dialysis. Is there a role for anticoagulation in those patients? And maybe the question is whether you're always kind of stuck with warfarin in someone who has just no kidneys at all.
Yeah, I think, once the creatinine clearances are below 15, there's no official indication for a DOAC, and you're struck with warfarin versus no clearance at all. While we do go to warfarin frequently, I want to point out that your risk of bleeding on warfarin with your creatinine clearance of less than 15 is almost 4 to 8-fold. So it's really a high risk. And unfortunately, I'm not sure there's a good medication therapy for people, but there's another choice we have, and that's a left atrial appendage occlusion device. So this is something called the Watchman device that the interventional cardiologist can occlude your left atrium and at least have a 50% reduction. You do have to be on anticoagulation for around 3 to 6 months with that. But after that upfront risk, you do have some level of protection that is worthwhile and something that I've instituted in many of my patients. So we do have another option out there, but more and more we're seeing people on no anticoagulation at all in that scenario.
Fantastic. Hey, I want to be really respectful of everyone's time. Thanks for those who joined us. Thanks, everybody. Have a great evening and take care, be safe, and hope to see you soon. Bye-bye.
Okay, thanks. Bye, everyone.